Thank you very much. My name is Paul Weiss. I am a professor of pediatrics in the medical school, health policy, and a senior fellow in the Freeman Spogli Institute for International Studies. And it's a privilege to be the moderator of this next very distinguished and interesting panel. I'm going to do a quick introduction of the panelists now. They will come up and do their presentation, and then we'll gather for interaction, Q&A subsequently. Our first speaker is Dr. Ann Arvin, who is the Vice Provost and Dean for Research here at Stanford, also Professor of Pediatrics, Microbiology, and Immunology here at Stanford. Ann has been a leading voice and a renowned scientist in the exploration of virus pathogenesis and has been a humane leader and mentor for now several generations of pediatricians and pediatric infectious disease specialists, both here in the United States and around the world. Her contributions and leadership have been recognized by multiple awards, including membership in the Institute of Medicine, National Academy of Sciences, and the American Academy of Arts and Sciences. And it's a great pleasure to have her on the panel. The second speaker will be Jim Gibbons, who recently retired as the Reed Weaver Dennis Professor of Engineering here at Stanford. He was also Dean of the School of Engineering between 1984 and 1996. He has been a pioneer in the development of semiconductor technologies and has been recognized also by multiple national and international awards. And most recently, his contributions have focused on the development of virtual video technologies and how it can be used to enhance communication, improvement of quality of healthcare, particularly in how providers and patients can communicate and interact using virtual video technologies. Our third speaker is Ben Robison, who recently graduated from Stanford Medical School. He's also an accomplished violinist who has been exploring how creativity, music, and the arts can not only improve community health, but also inspire self-reflection, in many ways self-healing among physicians, clinicians, and other caregivers engaged in healthcare in complex settings. And most recently has been focused on developing community health strategies that are particularly focused on improving health in Native American communities, particularly Rosebud Reservation in South Dakota. Our last speaker is Maya Rawson-Slater, who is an assistant professor in the medical school in the Department of Health Research and Policy, and has been doing really remarkable work in exploring, helping us understand how family dynamics, public policies can affect family and child health outcomes in actually very creative and important new ways. So with that, Ann, would you come up and present?
Let me start by just explaining that I really know relatively little about rural health, but I do know quite a bit about pediatric infectious diseases and immunizations. That's been the clinical part of the work that we've done in my group for quite a while now. So, and I'm also probably, I'm not sure of the numbers, but a relatively few number of Stanford faculty who actually grew up on a farm, if that's a credential. So what I thought I should do is just give you a few slides, 3 to be exact, and to talk about 2 examples of the impact of legislation on child health that we can discuss. And so I picked California immunizations data and then Medicaid coverage in rural US, Medicaid coverage for children in rural US. So the first one is this, this map of immunizations. What I wanted to highlight for you is, in the first case, is this immunizations in California. So probably you may know that in 2014 and 15, there were changes in the law having to do with what had been allowed under personal belief exemptions. And so those provisions in the immunization laws were changed. So we had an opportunity, that is the California Department of Health, had an opportunity to look at what happened with the change in those requirements. So this is data on kindergarten students, and it's the data showing the students that had all required immunizations by county with that change. And so what you can see is that compared to the 2015-16 school year to the 2016-17 year, so in a very short time, you can see a lot more green counties on this map. And so what we can show from that is the statewide percentage of kindergartners. And keep in mind, that's about 500,000, more than 500,000 kindergartners in California every year. The percentage that had received all of their required immunizations when they came for school entry went from 92% up to 95.5% overall. And if you had looked a year before that, there was an overall more than 5% increase in the children who came into kindergarten with their immunizations all up to date. So what the map also shows is that those increases were achieved in rural counties as well as metropolitan counties. And so we see, in fact, there are 2 counties that have almost 100% immunization rates, which, would you like to guess? One of them is San Benito, and the other is Tulare counties. So this is certainly a profound impact for our vaccine preventable diseases in California. The other thing that happened is that when we look specifically at MMR, which is measles, mumps, rubella vaccine, which is a critically important vaccine, the measles part of it for child health, we see that, again, the statewide percentages of children who had at least 2 doses of that vaccine went from 94 to 97%. And if you look at it in terms of how many counties had, so if you take the measure of how many counties had less than 95% coverage in the earlier time point, it was 53%. That rate has dropped to 30%. So again, another measure of what happened with this legislation. And so, of course, we know that in addition to the law, there were several events that shaped this, and not least of which was the measles outbreak at Disneyland. So that really heightened public awareness that you really can't just not vaccinate your child and think that it's all going to be okay because everyone else's child or many other people will vaccinate. So that was a very vivid illustration of the point. The other thing is that the public health departments and local providers really upped their efforts around all of this. And there are audits going on where schools are audited. The other information that is somewhat relevant here is that if you looked at rates of immunization in public schools only, these numbers would be even better than they are. Private schools are pulling the numbers down across communities. So that, I think, is just a snapshot of the kind of impact that one law can have on child health, and where we see the work being done in rural counties is every bit as good as what's being done in our own area. So, whoops, yeah. Okay, so next I wanted to really get out on a limb, an area that I know very little about, but luckily Paul knows a lot, so when we get to the discussion, he can chime in on this. But this is another change that you're all aware of, which is the changing rates of Medicaid coverage, and that includes the CHIP program, which you all know was recently, thank God, renewed. So this is the data that was looked at here was coverage from 2008 to 2014. And so in 2014, 2015, the good news is that the uninsured rate for children went to less than 5% for the first time ever in this country. And in rural counties, it was 6%. So not a tremendous disparity there. What this map shows you is the red is where more than 60% of children are covered by Medicaid/CHIP, and blue is 41 to 60%, green is 21 to 40%. So the gray areas are less than 21%. So what we know from the cumulative analysis of this data is that on average, 48% of children in rural areas receive Medicare coverage, and that's compared to 38% in metropolitan areas. So what we also know is that there was a big increase. It was 40% before the legislation in rural areas. So it's now 48%, and higher than that in many counties across the U.S., as you can see where the red is. So what this tells us is that the impact of Medicaid legislation was most important for those children in rural areas, and that means, of course, they are going to be more vulnerable if the changes are not sustained. So clearly, risks, benefits, and directly measurable impact of certain legislation on child health. So I will leave it at that for our discussion.
Thank you so much, Anne. Jim, would you like to come up?
So I'm going to spend the first two-thirds of my time here talking about an experiment that is driven entirely by members, physicians, neurologists that are interested in using telemedicine to treat patients with Parkinson's disease. And this is going to be a happy story from my point of view. This is an experiment that used virtual visits for treating Parkinson's patients. It was a 2-year-long experiment. We regarded it as a prototype for delivering patient-centered care at national scale. Focus, patient-centered care. The medical director of this was a man named Ray Dorsey, who has been doing telemedicine for his Parkinson's patients for about a decade now, and is a very strong proponent of it. Here is the basic experiment. 200 people with Parkinson's disease were chosen by the National Parkinson's Foundation. They were divided into 2 groups. The group represented here were going to receive usual care means visits to the offices of their neurologist, and 100 of them were going to receive their care through telemedicine. The aims of this experiment are listed here: demonstrate the feasibility of using telemedicine to deliver specialty care into the homes of patients, evaluate the quality of effect on the quality of life, the quality of care, and also related effects like decreasing the caregiver burden, saving time, reducing travel, environmental issues. There were 18 medical centers across the U.S. that were engaged in this. Here they are listed. And what you see here, among other things, is that there's a large concentration of them on this side of the country, and much smaller concentration on this side. And I want to point out a couple things. The quality of the organizations is suggested by the fact that if you believe U.S. News and World Report and look at the top 3 medical schools in the country, they are, in some order, which changes every year, Hopkins, Mayo Clinic, and MGH. They're all part of this study. They all have advanced interests in these kinds of things. So we've gotten a group of medical centers themselves that are representative of the very best medical centers in the country. This shows the 200 individuals I said were going to be selected for this experiment. Actually, at the end of the time, there were 195 across those 18 sites. These are the locations of the individuals who participated in the study. And this is, I guess I should have made a disclaimer here early. What I'm doing here is, I'm certainly not a Parkinson's neurologist. I was responsible for creating the virtual visit technology that's used for these experiments. Not so singularly, but this is to show you what it looks like. This is a woman with Parkinson's disease. This is a screenshot that we've set up for this purpose, but there is her neurologist, and behind her here you can actually see her laptop. So in actual practice, what's happening is she will be doing things on her laptop at the request of her neurologist, or in the event that it's an exercise routine, the first thing that Parkinson's patients get involved with is an exercise routine. Very important. Very important that they follow it. Very important that they do the exercises correctly. You need a coach to help you with that. It's a setup for that. You can have a coach over here instead of a neurologist saying, do this, and watching the patient do it. Here's a camera on their TV screen. She could be doing it with her laptop, but we've done it this way just so you can see. She could be, have her picture taken from that camera, and so that the therapist, wherever he or she is, could be helping be sure that these exercises are done correctly. She's going to be watching him do it. He's going to be watching her do it. That's perfect, right? That's an advantage of this technology that's hard to replicate. So the 195 participants were well educated and likely already receiving good care. That's an advantage for this experiment because it will mean that telemedicine is being judged against care that is already the best that is available. And I won't go through this entire chart, it's much too busy, but I do want to point out one thing here that will come back to Fresno and the Central Valley maybe. Participants that have ever used their desktop or laptop computer to participate in a video call or a video chat. All randomized participants, it was 53.8%. These are the ones that were getting virtual house calls, 97 people. 44% of them had done this. In other words, they'd never done a Skype phone call, a call of any kind. And among the usual care, it was larger, 63%, but certainly not 100%. People are unaccustomed to using the internet for other than email and searches. When you start trying to provide health care that way, it's sort of, hey, wait a minute, everybody's going to know what I'm doing here. So you have to have very secure technology. That's easy to do, and that's what we had to do. So the bottom line of this experiment is as follows. Virtual house calls are feasible and valuable, but not more or less effective than traditional care. Essentially, same answer. You get just as good care this way using the virtual visits as you do going to the doctor's office. A couple of details here. 97 individuals randomized to receive virtual house calls. 95% completed at least one virtual house call. 91% were completed on schedule. Quality of life. Quality of life for Parkinson's patients formally is estimated using what's called a Parkinson's disease questionnaire. It's been created by the community, the neurology community, to make as good judgments as they can about quality of life. Between the two groups, there was no significant change in using that measurement between the patients who got their care all on the internet versus in the office. Quality of care, also no significant difference. So those are fundamental findings to suggest that telemedicine for this disease is a very good way of providing care in the home with significant advantages. This is a busy slide, and I'm not going to try to explain all of it. I'll just say that the red bars are the community that got their care from office visits, and the blue bars are the video guys. And these titles down here, whoops, sorry, didn't mean to do that. These titles down here are unreadable, probably, but this is, over the 2-year period, this is a great deal better. In other words, the patients were a great deal better at the end of 2 years than before. Parkinson's is a progressive disease, so the fact that they get better is already something interesting. And what you see is, of course, what pleases the video folks amongst us was that there's better results with video, with the virtual visits than without. And that's the case. All of these are a great deal better, better, moderately better, somewhat better, but at least better. And what you see in that case is the blue bars are higher than the red. And this is a little better, but essentially no significant change. And this is a little worse and maybe a lot worse. So actually, the video visits are better in creating a positive result out here, not just the same or significant result. Physicians, generally satisfied. They had concerns about the quality of the connection. That's something that's going to happen over and over and over again. Here's connection quality. That means the bandwidth of your internet connection, fundamentally, and your willingness to use the internet for this process, for this care. So green is very satisfied, yellow is satisfied, and orange is neutral. So if you decide to be an enthusiast about the virtual care, you'll add all those three together, and you'll come out down here around 85% or something, where the care is, where the connection is, they were satisfied with it, very satisfied, or neutral. Care, the quality of the care, is out there around 95%. The convenience is out there around 95%. And the overall physician's image of this process is also out there past 90%. So, with the exception of the connection quality, the three things that we're most concerned about, care, convenience, and the overall estimate of the process, all positive. The next slide is for the patients. And of course, they're even happier than the docs. Connection quality they were less concerned about. The fact that they could see a doctor while they're home was mind-boggling for these people. This is really, really important. I'll come back to that. Their estimate of the care that they received was also significantly higher. These are now being compared, just the satisfaction with the virtual house calls, comfort and overall. I won't go into more detail there. I do want to use this slide for a couple of points. As the previous slides have shown, the patients did find care, convenience, and comfort satisfactory in the virtual house calls. Under care, I want to focus on this bullet. The regular intervals of seeing my neurologist through a virtual visit allowed my neurologist to treat more of my symptoms that emerged gradually. I do not have that kind of awareness of how my PD is gradually changing in once-a-year visits with a regular neurologist. That's really important. If you can stay in touch with your neurologist more regularly for short visits, total time, and you're not traveling to do it, that's a big deal. It really, really does help. Here's another on the convenience. To be seen by a PD specialist, I would have to drive 175 miles from my doorstep to the specialist's office, or further if it was the next closest specialist, 390 miles. Now, you want to treat a Parkinson's patient at home. That's where he lives. That's where you want to be treating him. By the time you've driven him 100 miles to get to his neurologist, it's not the same in the neurologist's office as he is at home. So you want to provide the care at home. And these distances are not trivial. I'll come back to that in a minute. But the total amount of travel that we believe we avoided in this 2-year study was 35,000 miles of it, right? Little environmental impact there, not much maybe, but here's something also very important. I really felt comfortable, did not feel like I was missing anything critical not being there in person. That's one really important point. The second one is, actually on top of it, I find it easier to be more comfortable expressing my PD by a remote device than I do face-to-face visit. That's true of all video for whatever connection. People who are separated from community connection through a video connection are willing to say things about themselves more and sometimes be a little more confrontational than they would in a social group. This is an important thing here. So that means you're going to get better care, the more willing you are to say how you're feeling. I won't go through there. So now I want to use 2 maps, following Anne's approach here. This is before I say anything about what that map is, I want to mention the woman who created it. It's a neurologist named Allison Willis. And the objective of the study that led to this map was to investigate the utilization of neurologist providers in the treatment of patients with Parkinson's disease, determine whether neurological treatment is associated with improved outcomes, kind of a basic thing. What they found was that the annual risk of skilled nursing facility placement and hip fracture between neurologist and primary care physician-treated patients was favorable for the neurologist-treated patients. In other words, something like 52% of all Parkinson's patients see neurologists, 48% don't. They see a primary care physician. Primary care physicians don't know the protocols, they don't know how to make judgments about what they're seeing and so on, of course, compared to the neurologists. What this study, in effect, was showing was that when you are cared for by a neurologist, the things that cause you other issues like hip fracture, falling over, premature death, those kinds of not minor issues, mean that you're much better off to get your care from a neurologist, whether it's in his office or virtually. Now, so that led Allison Willis to create a map where she could plot the proportion of Medicare beneficiaries with Parkinson's disease who do not see a neurologist. And what you find here is that the percentage without neurologist care, 77 to 100% of them, that's in this dark brown area. Here, for example, since Utah's part of our discussion here, a fair amount of that area there's no neurologist caring for Parkinson's patients in that area. Their fraction of Parkinson's patients is the same for their population as for the population in the US at large. So yellow places are good. That's not very many people without neurologist care. Brown places are not. Okay, and if you just draw a line here, you see over here, where also all of those medical centers were, there's a lot of neurologists to care for the population, and they're getting good care. As you move out, or it's yellow or a sort of light orange color. So that's what most of that area is. Out here, you see some nice yellow areas. That means neurologists are there. They may not be very highly populated, which may also mean that then people have to go to that neurologist to get them, to get their care. And then there's some fairly large areas out here on the coast, and in here somewhere is the Central Valley, where a fair number of people do not have a neurologist to provide care for them. So despite the fact that care from a neurologist improves healthcare overall and the probability of early death, et cetera, there's still a ton of people that do not get it and would be happy to get it by video if that's possible. This is a proposal that we are putting together at this moment. Turns out that the agency in the federal government that is most attuned to video visits of all kinds and for all purposes is the Veterans Administration. You might be surprised by that, but that's the case. And so what the Veterans Administration did in the year 2000 was encourage the creation of a number of PADRECs, they're called. That's Parkinson's Disease Research, Education, and Clinical Centers. There were 6 of them that finally won the prize, the funding to set up a center. These are really, really high quality centers now. They do everything and they do it at the top level of quality. There's one in Seattle, there's one in Portland, there's one in San Francisco, and there's one in West Los Angeles. In San Francisco, the woman who runs it is Dr. Carly Tanner, and she's at UCSF. Each one of these centers is actually run by a person who was a part of that Connect.Parkinson's project. So there's one in Philadelphia, one in Richmond, Virginia, one in Houston. And these little blue circles are the centers that are connected to this basic PADREC here. So yellow is the color that goes with the San Francisco Center. And so you see they are responsible for Parkinson's care, et cetera, out to the Colorado border. West Los Angeles is green, and they go into Texas. I don't know how Texas and LA ever agree on anything, but maybe there's something there. There's no blue circle there, so maybe that's good. If you wanted to do an experiment that focused on this community or a California experiment, you're really set up well for this because you've got 2 of these high-end centers and several connected clinics. And so that is actually the proposal that we are creating to the VA, which is to use telemedicine to provide care across this community here, at least in California, with 2 centers and a number of clinics. We may want to increase the number of clinics, et cetera. We're not sure what we're going to find when we get out here looking for video connections. Do they have the bandwidth? Will they actually use it? Those are issues that you can't force. If you want to do the entire West, well, let's see, the Rocky Mountains go right around in there somewhere, and one of the maps, if you take the Mississippi River as the dividing line, it's over here somewhere, well, you've got 4 centers, 4 of the 6 centers on the West Coast. So those are centers where veterans, at least, all the veterans in that area, could receive care that is eventually overseen by one or other of these PADRECs. In other words, very senior doctors helping people out here who may not even have a neurology degree, but they have been trained by centers such as the one in the University of Pennsylvania. There's a woman named Gwen Vernon who has a nurse's certificate program, which is extremely highly regarded because they in fact learn what to do with the diagnosis to help patients get the kind of care they need. It's exercise, medication, and diet in that order, and you need the neurologist to help you with that, but there's a lot of physical training and all that sort of stuff that you can be provided by other people. So there's a workflow here that corresponds to the patient's needs all the time. Medication, if you want to titrate estimate the value of a dose, whether you need to change it, if it's a patient's office, if it's a neurologist's office, the answer will be, well, take this dose here and then come back in a month and we'll measure. So now we can do it 15 minutes after you've taken the dose, if you wish. So those kinds of things are values that go with this. I won't go into that, I won't go into that, I won't go into that. I'm done. Thank you.
So David Lewis at the 2012 Rural Health Conference in Ogden presented a lovely paper on the Skull Valley Chute tribe, and in it he stated that the American Indian experience is the rural health experience. And so today I want to talk about Native American health, and in particular I want to tell a story about the Rosebud Reservation as a way to ground this conversation in a specific experience. And I might be a somewhat odd choice to do this. My background before coming to medical school was as a professional musician. I have an advanced degree in music and studied both improvising music and classical music, focusing on the work of Bela Bartok. And since that time, my research is focused mostly on medical education. But what I think I can do is bear witness to the experience in Rosebud, because I spent time there as part of a course that was offered, overseen by Dr. Garcia, and started by a former Stanford medical student, Krish Sumamarian. So I'll start the story by talking about jazz. And Jim and I, just a brief moment ago, were talking about his experience playing on the streets of Chicago, playing in the clubs on Rush Street. And anyone who has performed jazz can attest to the transformational quality of having an improvised experience and sharing a music that has a rich cultural legacy. And the reason I bring this up is that jazz emerged out of a poor, oppressed region of the United States, and it was due to 400,000 slaves who were brought to the Southeast, and then their cultures merged together with sounds and melodies from the Caribbean and spirituals that grew out of that region to form what is arguably the great cultural export of the United States. And I only start this talk by saying that because it speaks to Paul's question about what are the specific needs and how might Stanford speak to those needs. I think innovation, when we think about it, is often thought of in a kind of a supply side. We have these experts in these fields. We have these scientists in these fields. How can we use that information and that data to then go do something? But there's the reverse side of this, which is you find a need and you let that need then build the innovation or ask us the questions that then allow us to provide a deep service. And it's then the narrative itself is driven by that need. And I think that's a perspective that was driven home for me through jazz music. So, Rosebud. Getting to Rosebud, you fly to Sioux Falls, and then you drive 3.5 hours due west. And you get to a town of Murdo, which is about a population of 458. Then you turn left and you go south. And after about another 40 minutes on decreasingly taken care of roads, you end up in the town of Mission, which is on Rosebud Reservation. And I should say, neither the word Rosebud is not a Lakota word. If you want to talk about that area, it is the Sikangu Oyote, and they are, it's their nation there. And also, we often use the terms Rosebud Sioux, and that Sioux is also not a Lakota word. Anyway, as you're getting there, you notice the natural beauty. There are these rolling hills, there's the deep rivers, there are valleys and ravines, and there's a huge sky that just goes on forever. But what you also notice as you get into the town of Mission, which is about a population of 1,000, are broken windows. You see bloody shirts on the street, which I saw. You see needles and spoons. You see the detritus of a long-standing societal breakdown, and it is there in plain relief. When we talk about health, it's probably most useful to talk initially about the social determinants of that health. So the reservation as a whole is about 9,000 people. Unemployment is over 50%, and by some estimates as high as 80%. 89% of the people in Rosebud Reservation live below the poverty line. The average family income is under $18,000. The most startling statistic may be that the average life expectancy for a male in Rosebud in the United States is 47 years. And that is a year less than Haiti, to put that in a global context. So to turn more to the actual health data, Native American health spending is atrociously low in general. So healthcare is delivered at about $3,000 a person nationwide to Native American Indians through the IHS, compared to $12,000 on average for a Medicare patient. And we could also compare that to approximately $5,000 for a prison population. So this puts it in a larger context. In general, there are 10 times the rate of chronic liver disease and diabetes. And the physician labor shortage, and I confirmed this just 3 days ago talking to doctors from Harvard and Mass General on reservation, are on the order of 30%, on the order of 30%. So the chance of getting a primary care doctor there, the population difference is about 3,500 to 1 compared to about 1,000 to 1 most other places in the United States. So on Rosebud, over 43% of the population is obese. Youth suicide there is 3 times the national average. STI transmissions are 20 times the national average. They have 4 times the injury-related deaths. And when we talk about opioid epidemic, and it's declared a public health emergency, and that unlocks $57,000 total from a national budget. And we're talking about a town where they have triple the level of opioid dependence compared to African Americans and Latinos, which is already significantly higher than European and American population. So, and one last health statistic, and this speaks to recent events. In December 2015, the hospital there, which is an IHS hospital, shut down its emergency department for 7 months. And during those 7 months, the patients, and it was an incredibly active emergency department, but the standard of care had dropped so low that they were under threat by Medicare for not receiving funding, so they chose to shut it down rather than have it be closeted, which would be a multi-year process to come back online. People had to travel anywhere between 1 and 3 hours to receive emergency care. It is estimated this led to about 6 deaths that we know about, and at least 3 births that happened on transit in ambulances or cars due to the fact that these people did not have care. So the cause of this has been explored in numerous ways, but I would just speak to Sophie Tuhawk, who is the CEO of the IHS hospital and a dogged proponent for the health of the people in Rosebud. And she says it in a very simple word, that there's just despair from historical trauma. And she highlights the fact that massacre followed by relocation, followed by broken treaties, and then followed by even then the relocation of the children once they were on reservation over the course of 100 years has led to the state in which they now exist. To quote from a National Rural Health Association study from 2006, the forced relocation of children into the BIA, the Bureau of Indian Affairs, boarding schools, led to cultural distortion, physical, emotional, and sexual abuse, and the ripple effects of the loss of parenting skills and communal grief. And in case we want to relegate this to the distant past, this is only, it was only 1978 when that practice was actually discontinued. So Evelyn Spinoza, the health director for Rosebud, has stated, in addition to this, and that the issue on the emergency department highlights this, that it feels that they've had about 100 years of IHS providing bad, negligent, and in some cases, care that at the level of malpractice. But I also want to highlight not just the healthcare catastrophe that is there, but also the beautiful aspects of the place and the culture and the hope that is there. So there's the Sinte Gleska University, named after a 19th century Lakota warrior turned diplomat and peace advocate who was a strong and revered leader. This university is teaching nurses to become nursing assistants, is deeply involved in community health work. There's the amazing people there, people like Daniel and Rebecca Foster, who have been there over 2 decades. Daniel is an Olympic athlete. He is a psychologist. He went back and studied neuropharmacology so that he could actually offer more care to patients there. I got a chance to sit in on one of his sessions with a patient, and when we talk about high touch or personalized or care, he is a perfect example for me. He started this session with a Lakota ceremony where they turned to the 4 directions on the 4 cardinal directions. And I saw a woman who was in a deep level of mourning slowly calm down as they shared this ceremony. And then he started with a what I would consider a pretty typical counseling section, which was steeped in Western science and medicine. I mentioned Sophie Tuhawk, but I should also talk about Shane and Noelle Redhawk, who run what was called a few years ago the Buffalo Jump Cafe, but is now called the Sinkangu Youth Center, which provides oversight to numerous youths, getting them positive activities that they can participate, getting them off the street and away from alcohol in particular. I think there is the Red Coat Economic Development Center there, and they are very interested in economic visions of how they might rebuild their economy. So that question Chris posed earlier about what would lead to vibrant rural economies, and he was talking about from an energy standpoint and a climate change standpoint, but also from a health and healthcare standpoint. They are looking at, in just this year, on tribal exploration of self-governance of their healthcare system. And so when you think of something like that, that is something where I feel like Stanford could be of amazing benefit to this community as they try to understand the hurdles to developing their own hospital system, potentially. So returning to this idea of improvisation and need-based innovation, I'll just highlight the themes that I've already brought up. There's this immense wrong that exists of intergenerational trauma and a breakdown of the social fabric there. There are rural health opportunities that reflect real people, unique needs and values that are representative of the rural experience in general, writ large and in the extreme in this location. There's also this incredible culture that has so much to offer the outside world in terms of their sensitivity to each other, their families, and their environment. And the fact that there's these simply astonishing people that deserve of our respect and our care. More concretely, they have deep needs that they have expressed for education that leads to income, for well-paying jobs, for an economy that can return money to the reservation, and for healthcare independence. So what would a jazz-like innovation be? What would be something that is need-driven and yet offer a hopeful vision beyond taking care of a healthcare emergency? Well, there are possible solutions that we can see from global health. Groups like Narayana in India has a healthcare system where they offer cabbages for $2,000 scaled down to $0, and their error rates are the same as ours here in the United States. So there is ways of going about healthcare that are potentially radically beneficial, and as a place with tribal sovereignty law that allows them a degree of flexibility that they have partially explored, something like that is a possibility for them. There are things like debt-free schooling being explored by computer science schools in San Francisco that would be immensely helpful to them, to have students be able to do a nursing program and not have to pay for it up front. But this is just brainstorming, and what is needed is that we admit these shared challenges with the people, with the Sinkangu, with these reservations. And this is, I could talk about other reservations I visited, like the Havasupai or the Navajo Nation. But this particular example is so stark in that each community has something to offer because of their need, and because of their unique values. And that could inform how we use all this information that we generate here at a place like Stanford to then create even more value, both for them and for ourselves. And the reminder from the jazz metaphor is also that it was a complete melting pot that made it possible. It wasn't just that slaves came over from Africa, West Africa. It was that they combined with the Western classical instruments, the violin, the piano, that they were connected with the Caribbean melodies and the existing Creole culture in the Bayou in New Orleans. And it led to the works of Duke Ellington and some of the great works of the 20th century. So to return to David Lewis, he said, "Our stories bind us together as urban and rural Westerners, native and non-native, even as they divide us on the land that was the native West long before it was the rural West. Perhaps on native land, the most important healthcare innovations are yet to come. Thank you.
Hi, everybody. Thank you so much for inviting me to be a part of this conference. So I'm Maya Roston-Slater. I'm in the Department of Health Research and Policy. I am an economist by training. I'm not a medical doctor by any means. This is actually probably the most interdisciplinary conference I've presented at. So I'm really excited to be here. And a lot of my work focuses on maternal and infant health. So I'll be talking today specifically about pregnancy and infant health outcomes in California, and a bit about access to care, as well as other public programs. So just to put things in context and give you some numbers, despite being one of the richest countries in the world, the United States ranks poorly in terms of infant health. So in terms of infant mortality, we're 33rd out of 35 countries in the OECD. Preterm birth rates, so this is less than 37 weeks gestation, is nearly 10%. If you look at all countries with available data, 184 of them, we rank 130th. A new marker for an adverse health outcome is high birth weight. So it used to be the case that most statistics about infant health were focused on low birth weight, which remains to be an adverse outcome, less than 2,500 grams. But a number of studies have shown that high birth weight rates, so above 4,000 grams, is also potentially a risk factor for a variety of health conditions later in life, such as childhood obesity and diabetes. So that rate is currently 8%. There's some debate about whether high birth weight is more of a genetic thing, so larger mothers have larger babies, or if it has anything to do with behaviors during pregnancy, such as amount of weight gain. There's some evidence suggesting that the latter matters as well. And then finally, a recent alarming trend in the US is that the maternal mortality rate is much higher than in many other high-income countries. And in fact, we are the only country that has had a rising maternal mortality rate in the last decade or so. So one of the things that comes out of the work about health and health comparisons between the US and other countries is that one reason that the US ranks so poorly on these indicators of infant health is that we have much larger disparities, right? So what I was showing you just now are averages, right? So the average rate of high birth weight, for example, is 8%. But the distribution of outcomes in the United States is much more disparate than in other countries. So in particular, if you look at, for example, highly educated non-Hispanic white families, their infant health outcomes are quite comparable or even sometimes better than many other high-income countries. The reason that the US ranks so poorly on these indicators is because we have much, much worse health for families that are less educated, minority, and so on. But much of this work about disparities in infant health talks about disparities across socioeconomic status group, mostly in terms of education, ethnicity, and race. To the best of my knowledge, at least in the health economics literature, we know less about rural versus urban disparities, in particular in the Western US. So I decided to do a little bit of data analysis to just give you some statistics about these issues, particularly using administrative birth records data. So this is the universe of all births in California over 2009 to 2013. So first, if you just look at summary statistics or means of outcomes for rural versus urban zip codes. So rural here, you can define rural a number of ways. It doesn't really matter so much. But a rural zip code is defined as having less than 50% of the population that is urban. Okay? And then you just compare averages for things like birth weight, low birth weight, gestation length, whether there's any abnormal conditions of the newborn, whether or not the child died. What comes out of this, actually, is that, on average, rural infant health outcomes are quite comparable to urban ones. So, for instance, birth weight is actually slightly higher in rural areas than in urban areas. The rates of low birth weight are actually lower in rural areas than urban areas. The bold here means that these differences are statistically significant. The one thing that does seem where it does seem that rural areas are doing worse than urban areas is in terms of rates of high birth weight, okay? And this is something that I'll come back to later on. But it's important to understand that perhaps one reason that we don't see a lot of disparity when we just look at averages across rural and urban areas is because the composition of families and parents who are giving birth in rural versus urban areas is quite different. And this is a table that shows you that. So in rural areas, moms and dads are younger on average than in urban areas. The educational distributions are different, and perhaps the starkest difference is the race and ethnicity distribution is quite different. So mothers are much more likely to be non-Hispanic white and less likely to be non-Hispanic black or Hispanic in rural zip codes. So this suggests that if we want to understand differences across rural and urban areas that do not take into account, that don't just compare across these different compositional groups, you want to look within demographic groups. So this is what we do here. So what we're doing here is we're focusing on all non-Hispanic white mothers, okay? And then we're going to look at women that have high school or less education versus the women that have more than high school, okay? And here, what you actually see is, again, if anything, the differences are not particularly large, right? So rural birth weight is on average a little bit lower than in urban areas for non-Hispanic white mothers with less education, but these differences are not huge, although they are statistically significant. For white, less than high school educated women, actually rates of high birth weight are slightly lower than in rural areas and in urban areas, and gestation length is longer. But nothing really jumps out here as being dramatically different. When you look at Hispanic or non-white mothers, again, by education, what you see is that the higher rates of high birth weight rates is actually driven by these women, right? So in rural areas, we see higher rates of high birth weight among both women that have a high school or less, as well as those that have more than a high school education. Okay, so what have we learned so far? So if anything, if you just look at birth outcomes, these standard indicators of infant health, on average, these outcomes are, if anything, quite similar to in rural versus urban areas. But an important exception is high birth weight, right? And again, recall that this is a risk factor for a number of different conditions during childhood, including childhood obesity, hypertension, diabetes. Averages do mask some differences within socioeconomic status groups, right? So high birth weight, as we saw, is especially prevalent among minority women in rural areas. We've also done this sort of analysis looking at only poor areas. So we've limited our sample to zip codes that have above the median poverty rate, and the findings are generally similar. So then the next question I wanted to ask was, what about differences in access to healthcare and public programs, as well as differences in sort of pregnancy-related health? So this is a table that shows you that. And the thing that jumps out at you at first is that the rates of first trimester prenatal care initiation, which is an important marker for having the appropriate amount of prenatal care during pregnancy, are significantly and dramatically lower in rural areas versus urban areas, right? So about 75% in rural versus 83% in urban. And then if you look at things like whether or not a woman has any sort of pregnancy risk factors, so these are things like having a previous poor birth outcome, like a previous preterm birth, having fibroids or asthma, those rates are actually higher in rural areas and urban areas, suggesting that women in rural areas are actually the ones that need prenatal care more. The other thing that's kind of striking is that, and you also see this for infections. So infections during pregnancy are higher in rural areas than in urban areas. The other thing that's striking is that the vast majority of births in the United States are in hospitals these days, but there is a significant difference across rural versus urban areas. So about 4% of births in rural areas are actually not taking place in hospitals. Towards the bottom here of this table, I'm giving you some statistics on public program participation that are available in the birth certificate data. So the Women, Infants, and Children program, which is the largest nutrition program specifically targeting pregnant women and children under age 5 in the United States. Low-income pregnant women and children under age 5 in the United States. The rates of WIC receipt in rural areas are actually higher than in urban areas. I'll come back to this point in a minute. Rates of Medi-Cal coverage are higher in rural areas than in urban areas. But what's interesting is that also the rates of self-pay, so this is not private insurance, not government insurance, but self-pay are slightly higher in rural areas than in urban areas. You can also do this, again, in poor zip codes only. Looking at poor zip codes is important here because, these programs like WIC and Medi-Cal, only poor families are eligible for them. So this is going to tell you something about access to these programs versus just overall rates within the population. So the patterns for the prenatal care are quite similar, right? So again, women in rural areas are much more likely to initiate prenatal care in the first trimester than in urban areas. They're much less likely to have a hospital birth. Interestingly, though, in poor zip codes, women in rural areas have less take-up of the WIC program than in urban zip codes. And again, you see this higher rate of self-pay for pregnancy or delivery charges than in urban zip codes. So then, in order to try to get an even better sense of what are the differences across rural and urban areas in pregnancy care, healthcare access, and public program take-up, what we did is we estimated a regression controlling for all observable parental characteristics as well as any seasonality. So this is birth year and birth month fixed effects. So the idea here is to try to understand the differences in these outcomes for rural versus urban areas that are not accounted for all of the parental demographics, so things like education, the age of the mom, race, ethnicity, nativity, and so on. So the biggest, and here I'm showing you these coefficients. All of these are statistically significant, at least the 5% level, for different outcomes. So this is first trimester prenatal care initiation. This is whether or not you have diabetes or hypertension during pregnancy. This is other risk factors. This is whether or not you have a hospital birth, WIC receipt, and then whether you have Medi-Cal or other type of government health insurance. So again, you see that conditional on all of the demographics, pregnant women in rural areas are much less likely than women in urban areas to initiate prenatal care early. And this is a pretty large difference when you condition on all of the demographics. They're more likely to have diabetes or hypertension. This coefficient might not look particularly large in absolute terms, but it's quite large in relative terms when you compare it to the mean rate of these conditions. They're more likely, and again, this is statistically significant, more likely to have other risk factors. Again, you see that they're less likely to have a hospital birth. And then within these regressions, we're seeing a higher rate of WIC receipt and then a higher rate of Medi-Cal and government insurance. So I think the overall picture that emerges is that definitely it seems like women in rural areas are less likely to initiate prenatal care than in rural areas, in urban areas, and are more likely to have a variety of pregnancy risk factors. It's not entirely clear in which direction public program take-up goes. So in some estimates, we're seeing rural women are more likely to use WIC, for example, than in urban areas. In others, we're seeing less. Okay, so I have 3 slides here that try to think a bit about what all of this means and what kind of research questions one might have coming out of this and what it means for trying to improve rural healthcare access. So first, this striking finding about high birth weight, right? So it seemed like most of the other birth outcomes were quite comparable across rural versus urban areas, but high birth weight rates is the one that sort of stood out and is consistently higher, especially for minorities in poor zip codes. And then the other issues that, right, access to prenatal care seems to be much lower and lower rate of hospital birth. So one important question that I think emerges from this set of results is, what are the implications of the fact that women have lower access to prenatal care and are more likely to have a variety of pregnancy risk factors for their postpartum health? Okay? So we know a fair amount these days about what are the effects of various factors affecting women's pregnancies on infant health and child well-being later on, we actually know a bit less about what happens to the women themselves, to the moms themselves. A related issue is that if we're talking about poor women whose pregnancies are being paid for by Medi-Cal, a lot of them lose that coverage 60 days after childbirth, right? So Medi-Cal is relatively generous for pregnant women. It's relatively generous for children in terms of eligibility income thresholds. It's much less generous for women that have already given birth. Okay, so you lose your Medi-Cal coverage 60 days after childbirth. So if we're seeing, these low rates of relatively low rates of prenatal care take-up in poor zip codes and rural areas, it suggests that we might also see low rates of maternal postpartum care. And given the recent trends in maternal postpartum health in the United States, this seems like an important research question to explore, especially in rural areas. So again, it's sort of a mixed picture about public program take-up in terms of WIC and Medi-Cal, whether it's higher or lower in rural versus urban areas. So that seems to be worth exploring a bit more. But one thing that sort of jumps out is if it is the case that WIC take-up is actually a bit higher in rural areas than in urban areas, it may be one channel through which we see effects on high birth weights. So I have some research looking at the effects of the WIC program in Texas that suggests that actually it's associated with higher rates of high birth weight rates in Texas. So part of that could be due to the types of foods that are being given to pregnant women through this program. The other sort of interesting thing, and this is an ongoing project that I'm working on right now, is the details of the programs matter here a lot. So whether or not you take WIC is just a marker for having access to the program. How you receive that benefit actually might matter for the pregnancy health and infant health. And in particular, the way that WIC is delivered to women is that women are able to go to different types of vendors, small corner stores, large chain stores, or specialized WIC-only stores to receive their benefits. And the type of vendor that you have in your local area might matter for the type of food that you receive and the way that you receive your benefits. So we're trying to do some research related to that. And then finally, the fact that the rate of self-payment for prenatal care and delivery is higher in rural areas than in urban areas could be related to lower take-up of care. The other point that I should make is that the quality of care that's covered by Medi-Cal might vary substantially across rural and urban areas because of the way that that program is delivered. Rural areas only recently started implementing managed care systems rather than fee-for-service systems in California. And I have some research showing that managed care has differential impact on care and outcomes for families across different demographic groups. So that may also play a role in the differences that we're seeing. So that's all I have. Thanks.
All the speakers come up to the front table. Well, I think we all recognize that this panel reflects dramatic but diverse expertise and arenas of interest, but that in many ways converge on outlining both the nature of the challenges but also the opportunities associated with rural life. This is a time for interaction, questions. Please.
So the last panel was more about environment as a system this one seems to be more about poverty in some ways and its relationship to health outcomes. And so there are two interesting elements of this that, and I don't know whether they all get brought together. So I just have some questions. So first question is, obesity tends to be a big theme in these rural areas and probably tied to disadvantaged people to some degree. And so the first question I have is, what's our expertise at Stanford on obesity? Are we particularly strong in thinking about that, or is that someplace else? Second thing is, another theme in here that intersects with what we were doing with New Mexico is the tribal aspect of that. And we were actually did some work last summer on air pollution and fracking in a tribal area because of somebody who was associated, I can't remember who it was, that came to our conference that put us in touch with a tribe. And we do have a fairly strong program in Native American studies and a long tradition of actually running a big event every year about the tribes. And I'm wondering if there's something particularly important to do with the tribes, because they are on a different healthcare system. They have the Indian Healthcare Service. They have particular problems. So I'm trying to figure out where we can leverage our strengths here to look at, as we assess how Stanford could be, you know, it could have some influence in the West. And so those two things. And then the third question is, with the telemedicine, are there certain kinds of diseases that the telemedicine makes sense for, but not others? In other words, you're doing Parkinson's, but as we think about it, is that technology for a certain set of diseases, and are those the diseases more prevalent in the rural areas? So those are my questions. Okay.
So I can speak to the food insecurity, and it brings to mind two thoughts. One is that the United States is in general unique in the fact that we oftentimes combine food insecurity with obesity. So people are at once overweight yet they lack nutrition, and no more so than in Native American tribes. So the Supai that I briefly mentioned, all their food is brought in by 18-wheelers and then hiked in over an 8-mile trail to the most isolated place in the United States, which is in the midst of the Supai Canyon. It's an offshoot of the Grand Canyon. But if you look at what then stocks their store, it's meat, primarily red meat, processed chips and snacks, and high fructose corn syrup beverages. And it plays out immediately there. So the rates I said about diabetes in Rosebud don't even come close to what's going on in Supai in terms of that, which are closer to 80% diabetic or pre-diabetic there.
Yeah, I can make a comment on the obesity as well, but why don't you go to the second question, particularly around air pollution and environmental contamination in reservation?
That is not my expertise at all. The one I would speak to, though, the idea of collaborating with the...
We know
Yeah.
something about that.
Yeah, yeah.
But I think this question is, Native American populations aren't necessarily anxious to have outside people working with them.
That's right. So there's an effective program. So Krish, who I mentioned, has put in the time and the legwork. He's been there over 10 years now total. And just in the past year, COPE, which is the Community Outreach and Patient Empowerment Program, it was started by Sonia Shin, or continued by Sonia Shin, in Navajo Nation. And it is a program that is sponsored by Partners in Health in collaboration with the Navajo Nation. And it has been effective in training healthcare workers to then travel throughout the reservation. And they have just started a program at Rosebud. And I think that line of work, which begins with the collaboration, and I think here in particular, you mentioned the various Native American groups on campus, is something that I am personally continuing to reach out to. There are med students, Native American med students who I know and I'm talking to, and I think there's a huge opportunity to develop ideas that emerge out of both the community here but the local communities.
Jim, you want to mention your feeling about the characteristics of the medical conditions most likely to be addressed through telemedicine?
There's some role for, you'll have to accept the fact that I'm an enthusiast about telemedicine. There's some role in every medical application for telemedicine. The best way for me to prove that to you is to say that at the Mass General Hospital, virtual visits are in 190 different specialties. In urology, there are 4 separate specialties. Each one of them needs its own kind of care. So the issue is do the doctors get paid for virtual visits? That's the real issue. If they did, there'd be a lot more of it than there is now. We provide telemedical services to Joslin Diabetes Clinic in Boston, and to providers in the Mayo Clinic and so on. So all of the hospitals that we serve it's not just Parkinson's, it's a model for the way you provide care. And then the specialties, you have to customize things for each different application. But you can do that with the software. That's what we realized, is we can do these customizations with software. So the workflow is what you want it to be. And doctors really appreciate that, the efficiency. Possibility to do grand rounds from your office is extraordinary. So it's not limited to movement diseases by any means.
Can we get back to obesity too?
I also had one comment, just to follow up. For instance, the telemedicine could be immensely powerful on reservation if it emerged out of the desire from the reservation. And I think one phrase that came to mind in a discussion recently there was, we need entrepreneurs without borders, not just doctors without borders. And I think that maybe is something in particular that could be discussed here.
So I would just comment on that. I think the other thing that telemedicine does is amplify the ability of the local provider. If that person can connect with a specialist somewhere else, and I can tell you in infectious diseases and pediatrics, we are constantly on the phone with people in all kinds of less well supported communities. So it is a great opportunity there. It does come to how the reimbursement works, but in pediatric infectious disease, we never get paid anyway. So, but that's one question. But the other thing I think is kind of implied here is the very strong connection between pre-diabetic mothers, who are pre-diabetic in pregnancy, and high birth weight. So it is completely connected, to your point. We do have people in our School of Medicine who are very interested in obesity and pediatric obesity. So I think we could do something, perhaps with a focus on rural areas.
It's truly remarkable when you get, we do this Rural West conference.
Yeah.
It's truly remarkable, the rates of obesity out there. It's mind-blowing what you see.
Yeah.
I guess I could say. So one thing that I was going to say is, a lot of my work is about public policies that are not necessarily just about healthcare delivery, but more broadly social policy. And I've learned, the devil's in the details. And so understanding how a program is specifically delivered, and in particular how it's delivered in areas differentially. So an example, the WIC program, what kind of food you can actually get, where you can get it, who tells you how to get it. It's actually a much more complicated program than you might imagine in terms of what you can actually receive, I think matters a lot. And, and who's getting this program? It's pregnant women and children under age 5. And, we have a lot of evidence saying that early life factors have dramatic consequences throughout the life cycle, in particular related to health and obesity. So getting programs to deliver in ways that can prevent some of those conditions, I think, is an important thing. At Stanford, I guess CEPR, Stanford Institute for Economic Policy Research, is probably the better resources for individuals who are interested in policies and public policies in the U.S. And there's a number of people there, dealing with health-related policies.
I have a question for you. Did your analysis look at the maternal age at birth when the babies were born? Because that's generally a risk factor.
You mean in rural versus urban? So it looks like on average, rural moms are slightly younger than urban moms, but not by a huge amount, yeah. Mm-hmm.
We've been talking a lot this whole morning about powerful social forces, but also we're sitting at Stanford and are discussing the potential of enormous technical innovation. There is a logic to the creation of disparities in health outcome that unifies both of these arenas of activity. That disparities are created by elevations in social risk, the powerful social forces that are very dynamic in our society. We certainly have heard quite a bit about them earlier today, as well as on this panel. But we're also living in a world of dynamic technical innovation. And what is driving disparity, both in rural areas, urban areas, and the differences between these areas, is the collision of dynamic social forces and enormous technical innovation. When you have conditions for which there are very powerful, highly efficacious interventions, disparities will be dominated by the non-provision of those innovations. When you have relatively low technical efficacy, we don't have that much to offer, we don't really care about access or provision because elevations in social risk, these social dynamics, will dominate disparities in outcome. We've been talking about today earlier were a lot of these powerful social forces. We talk a lot about technical capability, but also with digital technology, with public policies, what we're talking about is enhancement, facilitation of provision of whatever efficacy we really have. And when you look at the outcomes in some of Maya's data, what we see is this picture of non-provision for highly efficacious interventions causing disparities, but also the dominating forces of dynamic social forces that are also being expressed ultimately in disparities in outcome. Stanford has the capability to address both, understanding and addressing these underlying social forces, but also understanding the mechanisms of provision as well as the creation of new efficacy. So I wouldn't want to confine our potential is here to any one condition or any one discipline, but rather look for more integrative approaches that really can address the full dynamic and underlying logic of the disparities we see in some of these data. I think our time is up, and we don't want to keep you from lunch. Thank you very much to our panelists.